So when we're talking about practical applications, we're going to just be with that, we're going to talk about mobile apps in the field and really disseminating what I think some of us have learned so far. And we'll take questions obviously at the end of the presentation, but at each end of each individual presenter's content, they'll have how you can reach them via email, and then they'll introduce themselves. So Dr. Stephen Chan and Dr. David Gratzer will let you know where they're from and how you can reach them as well. So my field that I am working in is really application of mobile apps in the integrated care settings. And so for those of you not familiar with integrated care, this really is a delivery model where a psychiatric support is provided to patients in the primary care environment. I love it because it's very directive and structured, and it involves this team approach that incorporates the primary care provider, the psychiatric consultant, a behavioral health provider, and the patient. And so we know from the literature and Concord reviews that integrated care is really a remarkable way of improving access to care. And it really shifts that treatment support to where patients are commonly presenting in the primary care environment for a lot of conditions such as depression, anxiety, and that sort of thing. However, working in this environment, there have been some challenges in reaching a lot of folks that struggle with real life issues that impede their ability to access care. And so in particular, we see difficulties with those that are underserved or have insurance but is limited, or that do not have insurance, as well as those who have experiencing higher health disparity rates, or have difficulties with socioeconomic difficulties. And so things that, simple things like trying to be able to afford to get to the clinic for transportation, or being able to get someone to, do the child care for their child in order to get to the appointment. These are all impediments to their care. And I was talking to my team and trying to really understand, how do we overcome these barriers, because we have this great system where we deliver psychiatric support in that primary care setting, but we're still missing these folks that are clearly in need, and they have that relationship with that primary care provider, but we're still struggling with being able to help them manage some of these things outside of that face-to-face clinical appointment. So we talked about the idea of using technology to really promote the care beyond the clinic walls, and to really understand how we can encourage the self-management through the use of technology. So the purpose of what we really are focusing on is leveraging that very effective integrated care methodology and incorporating technology into that to see if we can really reach these populations that are struggling to get access. And in order to do this, some of the things that we really needed to understand is really the facet of that population. So when we're asking patients to use mobile apps, we're asking them to self-manage their mental health conditions. We've started with depression. We're now working with some trauma-related apps, but we know that technology can promote some of our patients' abilities to self-manage, and can enable things like patient activation. And for those of you who are not as familiar with patient activation, this is really talking about their ability to have skill acquisition, education building, and understand some of that stuff, and then as well as engage in our desired behaviors that we're hoping to achieve to get to those goals. However, when we're using mobile devices outside this clinic setting, we need to understand these factors, in addition to how can we promote that independence and help them be active participants in self-management of their own care through the use of technology. So we really wanted to understand the idea of self-management and smartphone app-related factors, patient activation, and health literacy in using mobile apps related to depression in the integrated environment, both from a patient perspective as well as the provider's perspective. So we looked at smartphone ownership data and usage, and explored things like how have they used an app for health improvement? Do they currently use an app for health improvement? Have they ever downloaded a health related app? We looked at if they have a willingness to use an app for their self-management of depression, if they have data plans to support their use of an app, and some of those interest factors. We also looked at patient activation measures, which really helps us identify the patient activation measure will segment people into one of 4 levels, and the levels really indicate kind of where they're at on that trajectory to engage in self-management. So a level 1 indicates that there is a lower activation, that this person is really going to need a lot of direct assistance in their care. They really aren't understanding how they can play a role in their care, in comparison to someone who is a level 2 or 3, where they're starting to gain some of that knowledge and can be a little bit more proactive, but they do require some more hand holding. And then that last, the level 4, is somebody who's probably already engaged in some self-management stuff, and they've adopted quite a few positive health behaviors. So would probably be able to take something like an app that has some of those self-management features built in there and run with it. So we felt like it was very important for us to understand the population that we're working with. How does that factor into it? And then also health literacy was a component that we really wanted to identify if that would be something that we would need to be aware of in order to best facilitate self-management using apps. And so with the results, we had quite a few results, but I think what was important just to kind of identify is that there was a significant portion of the population that had smartphones, that a majority of them had unlimited plans, and that they had an interest in using their apps for seeking health information, and that they would be willing to use apps for depression related self-management. And they did believe that an app can really help them in their symptom management. And they, which was important for us to sort of fundamentally understand. We also found a distribution of the PAM levels were across the board. There was, I think the largest proportion was about 43% in level 3. However, there was about 20% at each of the levels, which means that for us, especially when we're looking at these health disparity populations, that it's important for us to understand a person's ability to self-manage and how we can use an app to tailor it to that person's self-management level. So giving them an app that asks them to do a lot of different things without really understanding, what their depression is and how they can engage in care is probably not going to help with engagement or sustained use. We really have to think about if somebody is struggling with understanding their depression, maybe we have an app that does a little bit more educational information and starts at a very simplistic level for them to sort of build that confidence and move them along that self-management trajectory. And so we've been exploring things with that. And then also we found that health literacy needs were pretty significant. And so it was important for us to, identify that, so that when we're looking at apps, that we're not utilizing apps that are going to be inappropriate in terms of literacy needs. So that's something that we're exploring as well. In terms of providers, a lot of the providers had indicated, verbally that they had an interest in using apps, but only one provider had recommended any mental health app. And they expressed a lot of concerns, especially with the population that they were dealing with, that their patients would not understand how to use the technology, that they were sure how to really support them, that they did want to have the patients, consider that, but they were concerned about their confidence in being able to support the patients in their use. And then if they were using these apps, how were they going to incorporate the data into their care? Was it going to be overly time consuming? They had some just real barriers and challenges for that. And then also, they kind of just indicated broadly that they did not think the patients would have the smartphone technology available, nor the data plans or willingness to use this, which is actually the complete opposite of what we found with the patients, that they had an interest, they had the technology, and they had the plans. So I think we have these perceptions that patients may not have these resources at their fingertips, but they really do. And so it was important for us to identify both from the patient and provider perspective, how we're limiting maybe the use of this technology. And so general implications, we explored quite a few apps with each of the populations, and what we have found is that there wasn't one app that was predominantly selected by a provider group or a patient group. What was clear is that one app is probably not going to meet the need for any one person for all periods of time. And there isn't going to be one app that a clinic will have that will work for everyone and every provider. What is probably more realistic is that things like becoming familiar familiar with the app evaluation model and getting comfortable using multiple different apps so you can leverage that expertise and tailor an app to a patient or to an individual need is going to be much more beneficial. And a big part of this is being able to personalize that technology and really being able to tailor it to some of those needs versus assuming that an app that has all of these features oftentimes can be pretty overwhelming for folks. So it may be better for us to tailor some of those app features to a patient versus overwhelming them with too many things. And the app, so I think at this point, what we're really working on is having a variety of apps that will work for different conditions and being familiar and promoting that comfort level amongst the team and be able to support the patients in using them. And part of this, you know, what we really found is that folks were very uncomfortable with their sort of technology education. And we feel like it's important for us to be able to pair some of those educational materials to the needs of the population. So considering how some of those health literacy deficits would factor into the materials that we're using to support technology and navigation with that is going to be crucial. In addition to making sure that we are providing some meaning and value. So the providers had some concerns about how and who would be responsible for incorporating the data. The patients really expressed that it was important for them to have a provider sort of recommend an app and that they'd be more likely to use an app if the provider recommended it. But they, you know, the providers were a little bit uncomfortable with that. So what we're working on is, because that integrated care team is that team network, we're using the behavioral health provider who works with the patient regularly and training them on how to utilize smartphones, familiarize them with apps, and tailor an app that we're trialing out now to really meet those patient needs, and taking into account like their ability of how they're able to self-manage and using some shared decision-making process to take that self-management level and tailor the content in the app and direct that patient to those areas. So hopefully we'll have data soon on effectiveness, but really it's about pairing, you know, that training, that education, and making the app use meaningful. And you know, it's been kind of a interesting way to do this. So I have 3 slides of references for you, but that is the, you know, some of the content that I'm doing in the integrated care setting.